Welcome, everyone. Thank you so much for taking the time to be here this evening. I'm Dr. Kristen Otto, Associate Member of the Department of Head and Neck and Endocrine Oncology, and I'm excited to introduce to you some colleagues of mine, and we're going to discuss clinical pathways in head and neck cancer tonight. In just a moment, I'm confident that you'll find value in the information that we share with you tonight. But before we begin, please advise that this content is not intended to be medical advice, and viewers should consult their physicians should they have any questions. The viewers should not rely on information contained in this presentation for immediate, urgent medical needs. Additionally, if you think you may have a medical emergency, of course, call 911 immediately. Never disregard professional medical advice or delay seeking care because of information contained in this presentation or webinar. Again, we're so pleased to have you with us tonight. Before I introduce my colleagues, I want to remind you that after we hear from our speakers, we will have the opportunity to have your questions answered by the experts. So we invite you to type your questions into our Q&A at the bottom. You can find the box located down there at the bottom of your screen. So now I'm going to go ahead and introduce my panelists. First, I'm going to tell you that I'm Dr. Otto, as I said, and I am a head, neck, and endocrine surgeon in the Department of Head, Neck, Endocrine Oncology. We also have Dr. Deepa Danan. She's an associate member head neck in the Department of Head, Neck, and Endocrine Oncology, and she is also a surgeon. We have Dr. Guilherme Rabinowits, who is a senior member in our department. He is a medical oncologist. And then Dr. Elio Monsour, assistant member in our department, who is an endocrinologist. So now what I'm going to do is I am going to go ahead and talk a little bit about our topic of the presentation tonight, which is Moffitt's clinical pathways. And I am going to go ahead and take the screen share and bring up the topic of pathways. I am going to go back to the beginning. So this is a topic near and dear to my heart. I serve as the medical director of the clinical pathways department here at Moffitt Cancer Center. And I really wanted to show the participants in this webinar tonight the amount of thought and work that goes into how we treat cancers at Moffitt Cancer Center. And we're going to highlight this by, of course, focusing on our most common diagnosis in the head and neck realm, which is oropharyngeal cancer. I'm going to scroll up to the top and show you that this pathway is going to focus on oropharyngeal cancer. The clinical pathways at Moffitt are live flowcharts that we create. The entire department and all key stakeholders get together and create these live flowcharts that really detail the clinical journey of cancer care from beginning to end. So this starts with the workup of any cancer and then leads through all of the necessary pre-treatment testing that is done, labs that are done, pathology that is done, any special testing on the pathology that is done, all the way through to any of the advised treatments, surgery, radiation, chemotherapy, all the way through to the end with surveillance and even end-of-life measures. All of this is detailed in these documents. We update these documents on an annual basis, and all of these documents go through very rigorous scrutiny by all the members of our department. And so what I really want to impress upon you is that when you come to Moffitt Cancer Center and get your cancer treated, you can rest assured that no matter whether you see me as a surgeon or Dr. Danan as a surgeon, whether you see any of the medical oncologists or any of the radiation oncologists in our department, you are going to get very similar care. And it is going to be up to the gold standard of care and up to other national guidelines. And so let's just begin with looking at our oropharyngeal cancer pathway. So, of course, we feel that we do it well at Moffitt Cancer Center. And the first item that you'll see is if you have this diagnosis, we recommend referral to a high-volume center with multidisciplinary head and neck team. So I want to throw that out to Dr. Rabinowits, and maybe you can make some comments on the importance of a multidisciplinary team in the treatment of a cancer like oropharynx cancer.
Thank you, Dr. Thank you, Dr. Otto. So, and thank you all for being here today. So it's, I think it's worth mentioning, since I'm not sure if you guys understand what the oropharynx consists of actually in the head and neck, right? So the oropharynx, when we talk about oropharynx, it's really the area that is actually encompass the back of the tongue, which calls base of tongue, which is the posterior third of the tongue. There's like the tonsils, there's the soft palate, which is on the roof of the mouth, and there's the pharyngeal walls around it as well. So like this is really what we're focused on our talk today. So the importance of a multidisciplinary team approach is head and neck cancers are very complex area to be treated, right? So you're talking about different specialties that has to come together to define what's the best treatment for these patients. Because not only we want to try to optimize the chances of curing when we're dealing with cancer in that area, but also we want to try to prevent them from having significant toxicities, like just trying to treat the areas that are more at risk in the area where the tumor is seen and the area where the tumor is not seen, but at risk of developing disease, microscopic as well. So having a multidisciplinary team, like where you have the surgeon, the radiation oncologist, and the medical oncologist together in the same room, reviewing the pathology with the pathologists and the imaging studies with the radiologists. In addition to that, like we also very fortunate to have like a complex group of people actually that deal with this disease, like nurses, social worker, speech language pathologist, a dietitian. They're all going to be following the patients actually through the moment that they were diagnosed to even post-treatment as well to make sure that they're doing very well. So in order to define really how to best treat these patients, since some patients may need just a single modality therapy, let's say just surgery or radiation therapy, while others will need a combination of radiation plus surgery plus chemotherapy as well with chemo and radiation. So having everybody together in the same room discussing and evaluating what the condition of the patient is fundamental to really optimize, like I said, cure chances, improve their chances to do well, not only from the cancer perspective, but from the treatment toxicities as well.
Excellent. So you'll see that, as Dr. Rabinowits pointed out, we actually detail all of that stuff in this blue box, which we call our workup boxes and pathway. Of course, it's important that you have a clinic visit. It's important that patients have adequate physical exam. And in the head and neck, one of the ways that we can see this area, the oropharynx, sometimes this is more sort of euphemistically known as the throat, but places like the tonsil or the base of tongue, is with flexible laryngoscopy. And that's when we place a scope usually through the nose so that we can actually see the back of the tongue and down lower, closer to the voice box. This, of course, is not the voice box, but areas just above. It talks about, the pathways talk about the appropriate imaging to do for the appropriate patient. So why some patients will need an MRI and others will need a PET scan, for instance, is talked about in the pathway. We talk about one of the most important kind of pieces of information in the workup of cancer of the oropharynx, cancer of the tonsil and base of tongue, and that's whether the patient has P16 or HPV positive disease, as we are more and more understanding the role of HPV virus, the human papilloma virus, as a causative agent for these cancers. Some patients actually need to be taken to the operating room and have an exam under anesthesia. And then, of course, as Dr. Rabinowits pointed out, things like a nutrition evaluation, because of course, cancers of the throat can very much impact a patient's ability to swallow. So nutrition is extremely important. A speech and swallowing evaluation is very important. A dental evaluation is very important, and down the line. So let's move down a little bit, and we come to one of the first decision trees of our clinical pathway, which is the patient eligible for clinical trial? And so I know I'm calling on you a lot, Dr. Rabinowits, but do we have options for clinical trials for patients with oropharynx cancer here at Moffitt?
We do. We have a series of clinical trials, both in the curative intent setting for patients with locally advanced disease to try to optimize their chances of doing well. And we also have patients with incurable disease who unfortunately develop metastatic disease to see maybe with one of these experimental drugs that look very promising in the lab, may translate to a much better outcome for these patients actually when testing that. And the clinical trials are so important nowadays. I mean, and we're so fortunate to have different options for patients here as well, because this is really how the field moved forward, right? So if we didn't have patients that would come and join the clinical trials and participate in the experimental drugs probably would be doing the same thing they were doing 20, 30 years ago, which were not great. The only way to move and improve the field moving forward actually is really having patient participation in clinical trial options to really advance, not only in terms of prolonging their lives, potentially getting a cure for those that are incurable, but also to make sure that they optimize their function post-treatment as well and maintain a good quality of life after that.
Excellent. And so clinical trial participation is very much encouraged and really can afford a patient a very good outcome. So as I talked about, one of the most important decision trees in the treatment of tonsil and tongue-based cancer, oropharyngeal cancer, is whether the patient has HPV positive or HPV negative disease. And of course, that not only impacts staging of the cancer, but it also impacts how we treat. So I'm going to move on to our more favorable status, which is the HPV positive patient. And I'm going to ask Dr. Danan to comment on the home plate that you see here, the definitive surgical treatment. So Dr. Danan, is there a role for surgery for this cancer, especially when it's early stage?
There certainly is a role for surgery in early stage oropharyngeal cancer, especially when it's HPV positive. We obviously take function into consideration very significantly because the back of the throat is really important in both speech and swallowing. So we want to maximize function while also treating the cancer. So if we are able to remove the cancer with clear margins, remove all the lymph nodes in the affected neck, if not both necks, the patient may be able to avoid having any adjuvant treatment, such as radiation or chemotherapy. And then we can follow the patient for surveillance. And if that's if that all goes well and they only get a single modality of treatment, the functional outcomes are excellent. So we try to reduce the toxicity of treatment and maximize function. And sometimes surgery is the best route for that. And we have some specialized techniques using a surgical robot, so robotic surgery, that we can access tumors in the back of the throat in a minimally invasive fashion, which we weren't able to do 20 or 30 years ago.
Excellent. So you can see that the pathway does detail exactly what Dr. Danan said, and this is because all of the surgeons who treat this cancer have decided that there are appropriate patients for surgery, especially in early stage disease of the oropharynx. And we've detailed the fact that, as Dr. Danan said, appropriate margins, and we feel appropriate as written here, 1 centimeter margins. And I'm going to zoom in a little bit so the writing isn't so small. 1 centimeter margins for mucosal tumors on the mucous membrane surface. And then, of course, as Dr. Danan pointed out, we always have to think about where can this cancer spread? And with this type of cancer, it's to lymph nodes in the neck is the common location. And so we typically will do prophylactic or therapeutic removal of lymph nodes at the same time that we do the surgery to remove the primary tumor in the throat. Sorry, let me go back. So as Dr. Danan mentioned, that some patients do require adjuvant therapy or therapy that's adjunct to the initial treatment modality like surgery. Adjuvant in this case would be either radiation therapy or a combination of radiation and chemotherapy. So if we click on the adjuvant box, you can see that we've also detailed exactly which patients require this adjuvant therapy and which ones we feel don't. And then of course you can see here that we have the clinical trial icon sprinkled in, which means we always have to be thinking about that clinical trial option. So maybe back to Dr. Rabinowits. We have here the decision tree about giving radiation with chemotherapy versus radiation alone. And we talk about risk features. And of course, we've decided what are the most important risk features. Do you want to talk a little bit about the risk features after surgery that make us want to give the additional treatments like radiation or chemotherapy or a combo thereof?
Sure, I'll be happy to. So if a patient undergoes surgery and you find risk factors like, for example, you initially didn't think that they have a lymph node involvement, but often when we do the surgery in the back of the throat, I mean, particularly like the base of the tongue also too, there's a high possibility that you have lymph nodes involved as well, microscopic disease. So it's a standard practice that you can also perform like what we call a lymph node dissection, right? So If you then find that you have a positive lymph node, this is what we call like an intermediate risk factor. If you find not only the lymph node, but if you find invasion into the vessels around the tumor, like the lymphatic vessels or the blood vessels around the tumor, if you had very close margin because maybe, for example, Dr. Danan were not able actually to get very good, clear margins around the tumor, like meaning that we know microscopic disease around it, give a good margin from the tumor that she's seeing as well. There's maybe a risk that there's microscopic disease left behind. So all of those risk factors actually tell us that we need to add radiation therapy after the surgery. There's two main risk factors actually that we really consider adding chemo plus radiation after surgery. One is if you have extracapsular nodal extension, meaning that you initially think that the disease is just inside the lymph node, but when we remove that, the pathologist look at it under a microscope and find out that the tumor actually was involving or going beyond the capsule that covers the lymph node. So this is one of what we call high risk factor that requires chemotherapy and radiation after surgery. The second one, if you have a positive margins, like so, even though every time they will go through surgery, we take the patient to the surgery, like we always have the goal of removing all the disease of clear margins. Occasionally, we end up finding a major vessel close to the tumor, and you're not able to get all that clear margin that you wanted from the tumor. And the margin comes back by the pathologist saying that you do have a positive microscopic margin, like on the surgical pathology as well. And this is the second main risk factor that we consider adding chemotherapy. In this case, the standard chemotherapy that we use for head and neck cancer that is approved is called cisplatin, which you see actually on the pathway as well. The patients are not candidate for cisplatin. There are other drugs that we potentially use, but cisplatin is the standard of care to this day and age.
And you can see here that we have detailed that for those patients that require both radiation, which is IMRT plus cisplatin, we have the kind of gold standard dose regimen, but then we also have an acceptable dose regimen modification, which is rather than giving high doses, giving slightly lower dose on a more frequent basis. And then for those patients who would not tolerate cisplatin well or have sort of risk features that say that they would do poorly with cisplatin, we have other options in the pathway, the carboplatin, paclitaxel, and the cetuximab. So moving on from, I'm going to go back up here and get out of the adjuvant page and go back to our HPV negative page and show you guys that the more advanced disease in the oropharyngeal cancers, we typically bypass surgery unless the patient needs surgery for just a biopsy or to confirm disease. And instead, we go right to non-surgical therapies, which we call our advanced local regional therapies. So these are the later stage tumors. We go right to the advanced local regional. And again, here you can see that the pathway tells us exactly how we offer or what kind of treatments we offer and to which patients in that particular setting. We detail what's the preferred regimen and then maybe what are some alternatives. So Dr. Rabinowits, again, I keep calling on you, but I think that highlights the fact that a lot of our oropharyngeal patients get treated non-surgically, at least up front. And you're our non-surgeon of the group. So let's go ahead and talk about the patient or the sort of decision trees about giving the gold standard cisplatin versus, say, carboplatin and paclitaxel versus cetuximab with the radiation therapy.
So for patients who are not great candidates for surgery, like we can treat them like with chemo and radiation, they actually tend to respond quite well as well. So and for patients, for example, if they have more advanced disease, that when we're reviewing the imaging and examining the patient, we feel that after surgery, they're likely going to need radiation, very possible chemotherapy. So instead of giving 3 modality therapy, we end up actually giving just 2 with the chemo and the radiation and reserve surgery for later if the tumor doesn't go away or it may be recurring in that area later on. But the majority of patients actually tend to respond very well and may not need this third modality of therapy. So, and that's why you need what we talked before, and I want to emphasize that the multidisciplinary team, because I guess if they only see the surgeon may say, let's just take him to the OR. If they only see the radiation, let's say, let's just do non-surgical management. But when all of us are together in the room, that comes like a long discussion to try to see what's best for the patient. And in terms of choosing what the best drug, as I mentioned before, cisplatin has been considered the standard of care for many years now. And this is because of there's randomized studies looking at cisplatin and radiation versus radiation alone, and they really found that that for certain patients with more advanced disease, they truly benefit from the addition of the chemotherapy. So when the patients have significant kidney problems already, they have chronic renal failure, or they have significant neuropathy or hearing loss, like those are potential risks from cisplatin as well, and you're trying to prevent them from getting worse from those symptoms. So, and that's when you actually tweak the chemotherapy and try to choose something that is probably not going to add more toxicity for their baseline comorbidities that they already have. That so if you have significant kidney toxicity, carbotaxol is a safer way to provide with the radiation. And there are studies actually that have shown, they have not compared cisplatin to carboplatin and Taxol, but we know that when you look at the studies that were done with carbotaxol and radiation therapy, you find very, very similar results that you see with cisplatin. So it's a well-accepted regimen to be used for patients who are contraindicated to go on cisplatin. Cetuximab is another drug as well. That's a non-chemotherapy agent, right? Both carboplatin and Taxol, which is two chemotherapy agents, or cisplatin, which is another chemotherapy agent. So they're in the class, what we call the cytotoxic agents of chemotherapy. Cetuximab is a monoclonal antibody. That's why we have the MAB at the end, which is basically what we call a targeted therapy, right? Head and neck cancer is overexpressed a receptor called EGFR, and the EGFR is known to lead to signals to the cancer cell to make them grow, proliferate, and spread. And so there are studies that were done in the past when you add the cetuximab to the radiation therapy, you actually improve the chances of controlling the disease than if you do the radiation alone. So that's also another option. It's a non-chemotherapy option for patients. But cisplatin is, again, if there's no contraindication for cisplatin, cisplatin has been shown to be a better agent than cetuximab in those settings.
Excellent. So once we treat patients, and then we have actually the fourth option at the bottom, which is, even though we sometimes want to give chemotherapy because we feel that the tumor would be best suited that way, sometimes we have to think about the patient, and the patient can't tolerate. So radiation alone is occasionally used even in advanced stage tumors for patients who we feel could not tolerate the extra toxicity that is, brought on by the addition of the chemotherapy. So let's then go on to our next box, which follows treatment, which is our treatment response. How do we assess the success of our therapy once the patient goes through therapy? So Dr. Danan, tell us a little bit about the schema here. So, we have the patient go through treatment, and at what point is it realistic to assess a patient for response to radiation and chemotherapy?
So radiation has a cumulative effect, so it continues to work even after the last treatment. So we tend to wait about 3 months to assess whether a patient has been cleared of cancer. So we usually get imaging about 3 months after finishing treatment. And from that point, we can tell whether the tumor appears to have, regressed completely, or if there's something that we need to keep an eye on with close follow-up imaging. And then we see the patient in follow-up and keep an eye on any areas that may be suspicious.
Right. And sometimes with oropharynx cancer, the post-treatment imaging is not 100% conclusive, right? So sometimes we wait that 3 months that we typically do, and we repeat a PET scan, and sometimes there's a little activity in a neck node. And it's always, a multidisciplinary and team discussion about how do we handle that? Do we consider that to be persistent cancer, so cancer that did not respond appropriately to treatment? Or is that just still inflammation and responding tumor, and maybe this tumor is just taking a little bit more time to respond? And we kind of think that way, especially if the scan looks better than it did before, but not fully resolved. And so I'm going to bring up this box here, this green box that tells us that almost all of these patients, if there is residual, activity, either at the primary site in the throat or in a lymph node in the neck, a multidisciplinary tumor board review is absolutely 100% appropriate. And I don't know how much you guys know about how we do our multidisciplinary tumor boards, but maybe I'll bring in Dr. Monsour. I know that you're not totally involved in the treatment of head and neck cancer as an endocrinologist, but certainly we have endocrine cancers that we treat and discuss via tumor board. Do you want to talk a little bit about multidisciplinary tumor boards and how they run at Moffitt Cancer Center?
For sure. Thank you, Dr. Otto. And so our multidisciplinary tumor boards are when we have our, weekly meetings where we discuss complex cases that may fall off this algorithm, or whenever we have a certain clinical question in mind on how to proceed, and we get the group's input on the best treatment course for the patient and the best next step. So we have radiation oncologists, surgical oncologists, medical oncologists, and pathologists and other specialists on the team to weigh in and give input. And that would provide comprehensive, cancer care. That way you get the decision and you get the expertise of everybody on the team.
Yeah, I like to say you get, 35 opinions in one when we discuss a case at the tumor board rather than just my opinion. But again, all of these treatment paradigms have been vetted through this pathways process. And so you can be, assured that if you do come and have cancer care at Moffitt, that you are getting not only gold standard treatment, but, evidence-based treatment and pathways-driven treatment. So on to assessing somebody's response after treatment. We mentioned that sometimes there's a little bit of residual activity and we're not 100% sure if it's persistent cancer or not. And so we even have direction in the pathway about when to consider things like ultrasound-guided needle biopsies of the neck. And of course, anywhere in the pathway that you see this blue underlined text, it means it's a hyperlink and there's more information behind it. So for instance, in this part, it says, in these instances, sometimes we can see false negatives. Let me just try to bring that up without the other box. Sometimes we can see false negatives, and that sometimes it's just important to wait another 3 months and get another PET scan before we make a decision to jump right in. And sometimes ultrasound-guided fine needle aspiration biopsy of a neck node can be helpful. Just like any point in the treatment of cancer, we get the patient through their treatment, and if the treatment has been a success and the post-treatment imaging is negative or improving, we then can go on to our surveillance box. And in head and neck cancer, the surveillance is typically shared between the multidisciplinary specialists. So back to Dr. Danan, how frequently do you see patients post-treatment for HPV positive? And I'll just kind of spill the beans here that even as much as HPV positive and negative disease is completely separate in terms of its staging and its treatment needs, we also have a separate schema for surveillance. Do you want to talk about surveillance of the different types of oropharynx cancer, Dr. Danan?
Yes, so for HPV positive disease, it tends to have better outcomes overall. So we don't have as frequent follow-up in the years after year one. The first year we see patients every 3 months, and like Dr. Otto said, we can alternate between the different specialists. So if you see me in February, you might see Dr. Rabinowits or the radiation oncologist 3 months later. And we obviously share a medical record. We get each other's notes, so we know exactly what's going on. If there's any concern for recurrence requiring a biopsy or surgery, and the patient is not seen by the surgeon, they will get sent to the surgeon without being, waiting an additional 3 months. So the first year we see patients every 3 months, whether or not it's HPV positive or negative. In the second year, if it's HPV positive, we'll see patients every 6 months or so. If it's HPV negative, we tend to see patients still every 3 to 4 months. And then after years 3 and on, we see patients every 6 months. And if it's HPV negative, for HPV positive, we can start seeing patients annually starting at year 3. Whereas for HPV negative, we would really only start that in the last year of surveillance, true surveillance, which would be year 5, after which we can call you cured, but still see you annually for routine follow-up.
Perfect. And you can see here that we have all of that detailed in this pathway, that we stratify by HPV status. And we include really all the things that we get that's pertinent to the cancer or side effects of the treatment. One of those side effects that we see with head and neck cancers, is particularly those that have been treated with radiation therapy, is hypothyroidism. I don't know if you have any comments about the post-radiation hypothyroidism, Dr. Monsour?
Yes. So in part of the treatment for head and neck cancer, as Dr. Otto mentioned, the important gland that's located at the base of the neck, called the thyroid gland, helps control your metabolism. And in part of your treatment, and in part of the treatment for that, it could lead into something called hypothyroidism, where the thyroid gland does not make enough thyroid hormone, a hormone that helps control your metabolism. And this can be seen as soon as 3 months after radiation, but may take years to develop. And that's why, and part of our pathways, we recommend to do an annual TSH, which is a lab to screen for hypothyroidism. Now, some people may not have any symptoms at all, or symptoms can be very subtle, especially in the beginning stages of hypothyroidism, whereas in later stages, some may experience extreme fatigue, weight gain, cold insensitivity, changes in hair and skin, and may also have constipation as well. So this is why we've incorporated in our pathway and ensuring that thyroid function is checked, as it is common and can be seen in up to 50% of people.
Excellent. Yeah. And, especially early in the post-treatment time frame, the first, couple months, 6 months, a lot of those symptoms of hypothyroidism overlap with just side effects of therapy and going through cancer treatment. And so it is important that we do the lab tests, and we recommend it post-treatment and then annually here in the surveillance plan. Just like with anytime we treat a cancer, sometimes our post-treatment imaging doesn't show an excellent response, and unfortunately shows disease recurrence or disease progression. And so we do have the home plate here where we can, understand and know, and we've agreed about what we do when we do see tumor progression. And of course, you'll see that these are usually very complex cases because most oropharynx cancer does respond to treatment first time around, and our outcomes are quite favorable for this cancer. But the first thing that we would recommend if someone does have evidence of disease recurrence or persistence is referral to a high volume center like Moffitt Cancer Center with a multidisciplinary team. I'm going to click on the clinical trial link here. So for recurrent oropharynx cancer, Dr. Rabinowits, what's your sort of thoughts, and what are you first thinking about in terms of offering clinical trials for patients in this setting?
Yeah, so we have a series of clinical trials ongoing, and really depends on what the situation the patient is in, right? So if they develop a local recurrence and they want to run surgery, there's options for clinical trials post-surgery to decrease further the risk of recurrence as well. But if the patients are not eligible for surgery and you consider maybe re-radiated, we also have other clinical trials for non-surgical patients that undergo recurrent disease as well. So it's really depends on what condition the patient is right now, what are the recurrences local versus distant disease as well. So there's a variety of clinical trials that are separated between those different patients that we see actually in this stage of the disease.
Excellent. So, I kind of bring this up to say that we do include the all available Moffitt clinical trials at any given stage and where they are appropriate, kind of sprinkled throughout the pathways. And so this really does help us to always have clinical trials in mind when we're treating patients, especially with advanced cancers or cancers that require multidisciplinary approach. As we go through, some patients are not eligible for clinical trial. And so then we have to talk about the disease recurrence. And of course, we ask the question about where is the disease recurred? Is it recurred just in a neck lymph node, or is it also recurred at the primary site? And then what options we have for therapy there. As we are starting to come to a close, I want to just highlight the systemic therapy options, because one of the most sort of important things that is a newer concept and certainly has been a very big success for patients with metastatic or recurrent unresectable head and neck cancer is immunotherapy. Dr. Rabinowits, do you want to just give a little synopsis of the use of immunotherapy in the setting of patients with recurrent or metastatic head and neck cancer?
Yeah, absolutely. So this is a very exciting time for the field as well. So immunotherapy, for those who don't know, is like a completely different class of drugs, where basically you're releasing the brakes from the immune system, right? You're trying to make your T cells, which one of the white cells, more active in not only identifying the cancer cells, but also eliminated that as well. So a few years back, actually, they started studying immunotherapy drugs in the head and neck cancer field for patients with advanced or metastatic disease. And not only they found out that immunotherapy can prolong life beyond what is expected from the standard chemotherapy drugs, but they also are much better tolerated than the standard chemotherapy. So you can actually really optimize the quality of life and prolong the life of these patients, right? Unfortunately, not everybody responds to the immunotherapy, but not everybody has a durable response to that as well. And that's why we have so many clinical trials, and the majority of clinical trials now have the backbone of the immunotherapy, right? So you're adding another one experimental agent to the immunotherapy to try to make it better, like so to see if we can find actually a synergistic effect where patients can do even better than what you would expect from the immunotherapy as well, and hopefully cure more patients as well.
Excellent. Just like with our radiation that can cause hypothyroidism, immunotherapy has some side effects. And we are very lucky at Moffitt Cancer Center in the head and neck department that we're not just head and neck, we are head, neck, and endocrine, because the endocrine side effects of immunotherapy can be prominent and problematic for patients. Dr. Monsour, any comments about some of the endocrine side effects of immunotherapy?
Yes. So, just like Dr. Rabinowits was saying, and part of the immunotherapy, which harnesses your own immune system to fight off cancer cells, and at the same time, it may result in thyroid dysfunction and pituitary dysfunction. Those are the two most common endocrinopathies that we see with immunotherapy. This is thought to be secondary to, an autoimmune related reaction. And so typically with immunotherapy, guidelines will suggest that we monitor thyroid function test, usually every 4 to 6 weeks, to screen for any thyroid dysfunction. And this could be seen up to 5 to 10% of people with the use of immunotherapy. And thankfully, this is something that is very much treatable, though, and shouldn't necessarily withhold your cancer treatment.
Excellent. So just in kind of in summary, this takes you through the journey of the cancer patient with oropharynx cancer. But I do want to just point out that at Moffitt, we've got a pathway for almost all of our cancer diagnoses. So I'm going to go back to our main pathways page and just show you that whether you have a head and neck cancer or a skin cancer or breast cancer, we have pathways that fit almost every diagnosis. And so your doctors at Moffitt Cancer Center really have put the time in to develop very complex and live documents that are updated on at least an annual basis to really highlight and expose the multidisciplinary nature and the evidence-based nature of our care here at Moffitt Cancer Center. So unless any of the other panelists want to point out any other topics on pathways, I will, anybody, any takers? No? I will go ahead and then introduce you all to one of our partners here at Moffitt Cancer Center, and that is David Curry. David is with the Moffitt Foundation, and he partners with the Head, Neck, and Endocrine program to ensure that we receive the research dollars we need to get clinical research off the ground and make advances in cancer treatment here at Moffitt. If you would like to learn more about how you can help, please contact David to find out more. David, would you like to say a few words about that?
Yes, I would, Dr. Otto. Thanks so much for leading the discussion tonight. And thank you, Dr. Danan and Dr. Monsour and Dr. Rabinowits. Your presentations were all insightful. And I think what they do is they share a lot of hope for those who might be listening and want to seek treatment here at Moffitt. And I also want to say thanks to my foundation colleagues, Stacy Price and Brielle Humphreys. They've been working hard behind the scenes to make sure that this is produced properly and we have a good presentation. So special thanks to them. And then finally, of course, I want to thank all the people who have joined us participating tonight and joined in the webinar. We've got patients, we have family members, we have even several of our donors who have joined tonight. You've given up your valuable time tonight to join us and to learn some of the world's very best. And so I hope you've enjoyed everything so far. And I would also ask that if you've been inspired by what you've seen and heard tonight, and you want to explore the many ways that you can help to support this important work, at your convenience, feel free to contact me, and we will explore those ways together. So it's a very popular part of our webinars now is the Q&A. So I'll turn it back over to you, Dr. Otto, and we'll move right into that session.
Excellent. Thank you, David. We appreciate all that the philanthropy department does to make research possible. And so now we invite you to ask any questions that you have of any of our speakers, myself or the other panelists. You may write your questions in the Q&A box at the bottom of the screen. I already have some coming up, so we'll turn to those in just a minute. I will go ahead and read the questions, and then I'll invite the panelists to respond as appropriate. So let's go ahead and start. So actually, interestingly, the very first question is, do we recommend radioactive iodine for Hürthle cell carcinoma of the thyroid? So that's interesting because it is a treatment that we do utilize in our department here. And maybe what I'll do is just give that over to Dr. Monsour to discuss use of RAI with Hürthle cell carcinoma of the thyroid. Big topic.
That is a great question. It's a very controversial question as well. I think so. The nomenclature for Hürthle cell changed to oncocytic, so we changed the nomenclature to that. And in regards to the use of RAI, there's been an increased amount of evidence that we now see some more RAI refractory type oncocytic or Hürthle cell cancer, but at this time, still more research is being done to further elucidate that. And part of the standard of care is that we still use radioactive iodine. However, I think with more data, we may see a change in that paradigm. And
I'm going to point out that, of course, just like with most of our cancers, we do have a pathway for the treatment of follicular thyroid carcinomas, and we include the oncocytic thyroid carcinomas within that treatment group. And we have very specific criteria that we use to decide which patients would benefit from the radioactive iodine, and that we've all decided on. So again, if you see Dr. Monsour or you see any of his endocrine colleagues, you know that you're going to get radioactive iodine in the same settings and for the same reasons. Things like significant vascular invasion, evidence of distant metastases, significant like positive margin after surgery. So these are going to be the very high risk features that would preclude predict a very high risk for cancer recurrence. So not all patients need it, but some get it. So let's go to the next question. Next question is, are you using immunotherapy with any of the treatment you discussed? I think we did address that. Dr. Rabinowits addressed that. I don't know if there's anything more you want to say about maybe when we use immunotherapy for head and neck cancer, Dr. Rabinowits?
Yeah, so the current approval for immunotherapy is really for patients with metastatic disease that are not curable. There's a lot of work that's being done currently in the patients who has curable disease to try to see if we can find ways of de-intensify therapy and still optimize the cure rates for patients who have a good prognosis, or for patients who have a poor prognosis, to incorporate the immunotherapy tool, what we're currently doing right now. But all of this is still investigational. It's under clinical trial. So we normally do not recommend to try to use that off a clinical trial, which is a more protected environment, actually, where people are watching very closely, because all of these drugs can also add more toxicity, right? So you may end up with something like from these drugs, actually, and not necessarily we know that there's a benefit of doing that. So really today, to this day and age, actually, the only approval in head and neck cancer for immunotherapy is in patients with, unfortunately, incurable metastatic disease.
So I'm actually going to skip down a few questions, because then there's sort of a follow-up question, which is, how much are the question is, how much are trials that are going on at other institutions reviewed by the Moffitt physicians to determine whether a patient might be fit for a trial outside of Moffitt that maybe isn't available at Moffitt Cancer Center?
And I can answer that. So it's so I usually do that with my patients as well. So if you don't have a clinical trial available for that particular patient as well, I usually tell them there's a website called clinicaltrials.gov that everybody has access to. That you can actually just go in, and there's it's www.clinicaltrials.gov. And if there's search box that you actually look at, let's say you put it, I have a head and neck cancer, and then you put in the search box, and a list of clinical trials that are happening across the nation actually is going to pop up. And you can actually click in each one of them and get a little more information about the trial, and including the institutions that they have that. But a lot of this stuff could be a little overwhelming for people who don't quite understand that as well. So I usually help my patients actually going through that, right? So I actually usually I look at clinicaltrials.gov and I tell my patients to look at that as well. And if they find something that they think may be interested in, they can send it to me and I can review that with them. And so again, like we're not here to put any barriers to any patients, right? Like, so of course, if there's something that looks very promising, better that we can offer at Moffitt, I'm going to do everything that I can to help that, because at the end of the day, our goal is the same as your goal, right? To help the patient, right? So, and we'll make contacts. We know a lot of people across the country as well, like that does head and neck cancer as well. So we're here for you. So we're going to help you identify what the right clinical trial for you, what we think is probably the best bet, and we'll help you through the process.
And then back to pathways, I'll point out that, we currently include Moffitt-based clinical trials in that are behind those clinical trials links in our pathways. So those are things that we write in our documents, but everywhere you see a box that says multidisciplinary tumor board review, you can be assured that that kind of information is being discussed. So if it happens to be a trial that Dr. Rabinowits isn't aware of, but one of our other physicians is aware of, and it's appropriate for the patient, and we don't have anything appropriate for the patient, of course, that will be discussed in the setting of tumor board and will be then relayed to the patient. So we don't ever obviously withhold treatment just because we don't have a trial available, and we are constantly reviewing trials available in other institutions, especially for those patients who need trials, because they tend to be very, very special and sort of advanced and really need the help. I have a great question in the chat, which is, are the clinical pathways available to view on the Moffitt website? And unfortunately, I have to say that for the patients, they are not, but I think that would be an amazingly good resource. And so I think that's something that we really need to think about. Right now, the pathways are viewable only to the Moffitt physicians and practitioners, but certainly developing a patient-facing site for the pathways would be an excellent idea. So I will certainly take that one back to our pathways department for further consideration. I appreciate that question. Another question: I have thyroid cancer and have been on a combination of BRAF/MEK inhibitor. What's next? What's in the works or showing promise as another treatment option in the course, if the course of treatment stops being effective? I'll talk a little bit about that, and then maybe I'll turn that over to either Dr. Monsour or Dr. Rabinowits. And what I'll say is that this sort of highlights one of the things that we do discuss in our pathways for thyroid cancer, which is next generation sequencing of all of our tumors. And so especially in thyroid cancer, understanding the molecular drivers, the mutational drivers for tumors really has opened up, just like immunotherapy in head and neck cancer, mutation testing and understanding the mutational drivers has opened up an entire world of treatment for patients with thyroid cancer. And so I think that is always a process in evolution, and next generation treatments are always currently being developed. Any comments to add to that? Maybe Dr. Monsour?
Yeah, I was just going to agree with you, Dr. Otto. I don't know if I have more to add that other than the role for next generation sequencing to see if there are any targetable mutations, and then the role for other adjunct agents that are like otherwise being researched. Maybe Dr. Rabinowits might want to weigh in if there's, any new things or exciting things in the pipeline.
Yeah, and the other thing also too, like it really to provide best possible guidance. Like there's a lot more information that we need to know, right? So my sense is because your place on those drugs is because you have a mutation on a gene called BRAF. That actually those drugs tend to work on that. But I also don't know, like, if this is like a more aggressive type of tumor, it's anaplastic because it may act a little bit different. If this is not such an aggressive type of tumor, like a papillary or well-differentiated thyroid cancer. So it's hard to really guide you in terms of what other therapies we could offer you without having more information. So, I'm happy to discuss that with you, like offline as well. Like, if you wanted to, I'm happy to see you and evaluate everything that has been going through. So it's going to be very challenging now to really guide you in what other options we could offer you, like not having more details about the whole history and what you've been through before as well, and how you're feeling and how you're doing. So, but I'm happy to do that anytime if you want me to offline.
Excellent.
Yeah.
So there's a question, because now we're sort of conflating both head and neck cancer and thyroid cancer. So somebody writes in the chat, how do head and neck cancers relate to endocrine cancers? What I'll say about that is that it's proximity, I think. So our department is a combined department of head and neck and endocrine. So many of our practitioners cross over between treating head and neck cancers and, of course, the most common endocrine cancer, which is thyroid cancer. As a head and neck surgeon, actually, my practice is very much geared toward just operating on thyroid cancer, and so that's how they're related. They're close together, and our doctors treat the same cancers. I think this is a great question that came up in the chat, and I think you started to allude to this already a little bit, Dr. Rabinowits, is how do I know that I'm eligible for a clinical trial?
So every clinical trial is going to have a strict exclusion criteria, meaning like, even though we may talk to you about a clinical trial and a study that looks very exciting and promising, and you say like, yes, let's do it. I mean, like there's going to be a bunch of checkbox that needs to be filled to make sure that you're eligible for that trial, right? And every trial may have a little bit different exclusion criteria. So you have to go through this checkbox to make sure, let's say, like some of them, like, so just to understand, is like, it's your blood counts within normal limits, your kidney function is normal, your liver is okay. I mean, is there any recent cardiac event? Are you, like, I mean, do you have any bleeding disorder, depending what drug you're going to go into that? Some of the trials also may say like that the tumor is very close to major vessels or close to like your airway or your stomach that may cause perforation and things like that. They'll say you're not eligible for that because it's too risky to go on that specific drug. So it's hard for you to vision that by yourself. I mean, I think you really have to partner with the doctor, the physician who's actually discussing to you about the clinical trial options, so they can go in details with you about all the potential checkbox to confirm that. And that's why when you go to the clinicaltrials.gov, there's no way they will know that for sure. Like, so if you find a trial that you're interested to, you may contact the institution because the number is going to be there. And they will say like, we need all your medical records, we need your information, and you may need to come to our visit actually so we can examine you, make sure there's nothing that would contraindicate you for going on the clinical trial. So it's very specific for each trial. It's like, unfortunately, it's not one size fits all.
Excellent. Are there new treatments for other types of cancer that may also work on thyroid cancer? That's a great question, and really leads back to, I think, the next generation sequencing of tumors. As we understand about the molecular drivers, whether it's a BRAF mutated melanoma or a BRAF mutated thyroid cancer, treatments can be very similar, can be similar drugs, similar regimens. And that's really how we learn from each other. And, you know, we're fortunate at Moffitt that we do have all of those teams available and that are sort of cross-referencing, you know, their treatments. So absolutely. Here is another great question, and I'm not sure if we have an expert in this, but maybe Dr. Rabinowits again. I saw the latest news on TIL therapies. Will we be seeing this in head and neck cancer treatment? I don't know who wants to take that, Deepa or Dr. Danan or Dr. Rabinowits?
I can talk about it.
Okay.
I mean, like, so this is actually a great question. It's a great timing. Like, we're actually super excited because we recently opened a clinical trial with TILs. For those who don't know, this is tumor infiltrating lymphocytes, and was recently a big thing in the news because melanoma was the first solid tumor that actually got approval for TILs. Before that, it was only for leukemias, lymphomas. I mean, like, so this is actually a very exciting timing. And we recently opened, and I can tell you like that the leaders on the field actually on TILs actually were at Moffitt, right? So they are at Moffitt as well. And like, and when you see actually, if you see the publications, actually, you see actually their names down there as well, people that work closely to us as well.
Yes, and we just added that as a treatment in the melanoma pathway. So I know the pathway. We just published it, and so yes, it's approved, and it's very exciting.
So, but just to answer your question, so we just opened a trial of TILs for patients with advanced disease, like patients who actually have metastatic disease. But this is really for patients on first-line therapy. And that's why we try to advertise that as much as we can to the community, like for the other physicians as well, because when somebody comes with advanced disease, they tend to start them on standard of care treatment, let's say the immunotherapy without chemotherapy, which is the current first-line treatment for patients with advanced head and neck cancer. And we try to make them not do that, like, so the patients can really and clearly hear all the options they have before they actually jump into the next step. And so we do have a trials with TILs right now with tumor-infiltrated lymphocytes that is ongoing and accruing patients. And we want to see these patients before they start on therapy, because if they already started on therapy somewhere else, unfortunately, you're no longer eligible. It has to be first-line therapy. So that was a great question. This is a perfect timing for that.
Very, very exciting stuff. How many head and neck endocrine clinical trials are available at Moffitt right now? I don't even know if I have the number or a list.
So this is keep evolving, right? Because we end up closing a trial, opening another one. So this is actually a very fluid, right? To keep going. But I think we have around probably maybe 14 trials, 12 to 14 trials. And some closing, others opening, and some still there, some's about to close. So there's a lot of, and in different settings actually for head and neck cancer patients. So there's multiple trials ongoing right now.
Excellent. And the nurse informaticists that update our pathways for us keep an eye on the opening and closing. And so they do make sure that the lists are as accurate as we can, keeping up with the opening and closing of trials. Next question on the list. Maybe I'll turn this one to Dr. Danan. What do you recommend if an ultrasound of the thyroid shows a nodule as TR4?
So I think we need a little more information regarding the
Yes.
size of the nodule. So we would need the full ultrasound report. Potentially, if you were seen here, we would repeat the ultrasound to know whether or not a biopsy was needed. But I think that information alone is not enough to give you a good answer. I think we would need more information from the ultrasound report.
Agree with that completely. So a TR stands for the TIRADS. It's an American College of Radiology scoring system for thyroid nodules, and TR4 is a suspicious nodule, but it only gets biopsied if it's over a certain size. So we use the TR or the TIRAD system to basically score our level of suspicion and then dictate which nodules require biopsy and which nodules can safely be watched and do not require biopsy or further intervention. So next question, what happens when a trial closes if a patient's having a positive effect on that treatment? What happens then?
So it's often the trials actually when they're written as long as the patient is benefiting from the drug and not having significant toxicities and continue on trial, often the patients continue on the drug and the company continues to provide the drug unless end up being approved by the FDA, and then actually it goes through the insurance right after that. But but there are some trials that say the treatment is going to be given for 2 years, or the treatment is going to be given for 1 year, and then even if the patient is benefiting from that, they will stop the trial because the plan was to treat that for 1 year. So it's really every trial is different, and all of this is specified. When you sign an informed consent, you will know that up front as well. So, but of course, there have been cases that they said oh, the patients were really benefiting from that. The time has passed, and they actually discussed with the company, and then maybe they found a level or that they could potentially continue with that. It's really dependent on the sponsor who's doing that and what benefit the patient is getting and what's going on actually. So there's multiple factors that influence that decision. But many trials I've seen that they close for accrual because they completed, patients still benefiting. They close the study, they're looking for survival after that and all this stuff, and the patients keep going on the drug for sometimes you see for years actually. So this is really a discussion we have if it's not already pre-specified on the informed consent on the clinical trial protocol already.
Excellent. And that actually does it for our questions. Does anybody else have any additional questions to add to the chat? No? Oh, so the TR4 nodule measures 1.8 centimeters. So technically that would meet our criteria for biopsy, as a TR4 nodule over 1.5 is typically biopsied. Next question. My trial offered compassionate use, so thought it was good to share. So as Dr. Rabinowits mentioned, that occasionally there is an opportunity to continue drug therapy despite the closing of a trial. So that's about it. That wraps up our session for tonight. Thank you all so much for being with us, and we really hope that you found this webinar informative. I'm very excited about our clinical pathways program and the fact that we have all of our treatment schema written down. I think that's an amazing thing, and kudos to the programs for getting together and making sure that happens. And thank you so much to all of our participants for your interest tonight and being part of this. We appreciate your continued support as we work to revolutionize cancer care and also, of course, provide the best possible outcomes for our patients. Thank you very much.